nós temos como moderadores o Dr. Arno von Risto, que está substituindo o Dr. Zé Luiz Camarinha, e o Dr. Vascular da Fonseca. O nosso debatedor convidado, o Dr. João Batista Barreto, ele teve um acidente com o filho e vai ser substituído pelos próprios moderadores que vão discutir os casos. Então, acho que sem muita perda, nós vamos iniciar as nossas apresentações.
Boa tarde. Essa é uma mesa muito interessante, eu acho que com discussões que não são do dia a dia da cirurgia vascular, mas que são de extrema importância, porque permitem que a gente possa estender a terapêutica a um grande número de pacientes que, na verdade, muitas vezes perderiam a vida tendo lesões que são tratáveis atualmente. Nós temos a honra e o prazer de ter na nossa mesa o Dr. Thomas Bauer, que é o chefe da cirurgia vascular da Mayo Clinic, com uma experiência enorme, talvez a maior experiência mundial, o hospital dele com esse tipo de reconstrução. E também temos a presença do Dr. Enrico Asher, de Nova York, que vai nos falar sobre procedimentos endovasculares nessa situação. Teremos a presença também da doutora Cristina Righetti, que é uma experiência importante em nosso meio, e eu mesmo também vou fazer uma apresentação. Eu gostaria de ter o prazer e a honra de convidar o Dr. Tom Bauer, que, como eficiente cirurgião que é, já está no pódio. Tom, please.
Mr. Chairman, this is my third trip to Brazil, my first to Rio. I must say your country and your city are beautiful. I'm absolutely honored to be here, and your gracious hospitality is unmatched, in my opinion. It's a pleasure to talk to you today about our experience with open surgical reconstruction of the vena cava and the iliac veins. Iliocaval obstruction is most often due to chronic thrombosis or malignancy. Endovascular interventions are first-line therapy in benign disease, but surgical bypass generally is reserved for those who fail endovascular therapy in benign conditions. Though in malignancy, the data clearly now have firmly established the technical feasibility of vena cava graft replacement in select patients. We'll first begin and review our benign experience, published in 2011. A lot of this work is done by my partners Peter Glavitsky and Manju Kalra, but there were 26 males, 34 females, mean age of 43 years. The most common indications were leg swelling and venous claudication in at least 90% of patients. Mean symptom duration was 6 years. About 1/3 of the patients had healed or active ulcers. The pathophysiology was obstruction and reflux in the majority of patients. If we look at the 64 procedures, the most common operation performed was a palmar procedure, a femoral crossover bypass, utilizing saphenous vein in most patients. Other patients, though, had more complex reconstructions. Iliocaval, femoral caval, complex bypass, and hybrid reconstructions account for the rest. And in these patients, about 1/2 had arteriovenous fistulas placed. Our preference for a palmar procedure is use saphenous vein if it's at least 5 millimeters in diameter and it's tunneled subcutaneously. We've trialed endovenous harvest. We've had a few patients that have had a little burn close to the vein, so we've gone back to harvesting the vein surgically. If the saphenous vein is less than 5 millimeters, and especially if there's poor inflow through the deep femoral vein and we have to use prosthetic, an AV fistula is added. Iliocaval or femoral caval bypass is done through a midline or flank incision. We prefer grafts 12 to 14 millimeters in diameter, and these patients all will get an AV fistula, and most of them are anticoagulated with warfarin for a minimum of 3 to 6 months. This is a patient that Peter Glavitsky did, a 61-year-old gentleman that had bilateral iliac and distal IVC obstruction and also had a prior vena cava filter that had thrombosed, and he did a complex iliocaval and femoral caval bypass with an AV fistula in the right groin. Hybrid reconstructions have been trialed. This is for long segment disease extending from the cava into the common femoral veins. With this procedure, we excise the synechiae and the common femoral vein. The iliocaval segment is recanalized. Stents are extended into the common femoral vein as shown in the left lower picture, and then the vein is closed with a bovine pericardial patch. Among these 60 patients, there's been no deaths and no patient has had a pulmonary embolism or deep vein thrombosis. However, 13 of the grafts, or 20% of the group, failed early, of which 11 were successfully recanalized or restored by surgical or endovascular techniques, yielding a discharge patency of 95%. If we look at secondary patency of these open reconstructions, I've highlighted an arrow here to show the 3-year mark. They're excellent for iliocaval reconstructions and palm of vein procedures, approaching or exceeding 80% at that time frame. But you can see if we look at the 12 hybrid reconstructions that have been performed, the results are really dismal at 1 year with only 30% secondary patency. Ulcers healed in 83% of the patients. However, 5 of those 10 patients developed recurrent ulcers, and 3 of those 5 individuals had patent grafts at the time that the ulcer recurred, indicating that the reflux disease below the groin had worsened. Let's shift gears now and talk about malignant disease. Basically, caval malignancies fall into 2 categories, primary or secondary. The most common primary tumor is venous leiomyosarcoma. It involves a suprarenal segment in 40% of patients and is more common in women. Secondary tumors fall in 3 categories: retroperitoneal sarcomas, primary or metastatic liver cancers, or pancreaticoduodenal cancers. And there are a subset of patients that have secondary involvement of the vena cava because of intraluminal tumor thrombus, of which renal cancer is most common. We use CT and MRI imaging with venous phase to define the location and extent of the tumor to help define the level and extent of venous obstruction in the venous collaterals. The general principles are that patients with localized disease, good performance status, and good cardiopulmonary function are offered operation as long as there's no metastases. Our preferences for prosthetic conduits. We like these because they're readily available and the external rings help resist visceral compression. In deference to the UCLA group that prefers smaller diameter grafts in this position, we prefer larger diameter grafts, the largest of which is 20 millimeters. And we like to keep the rings close to the anastomoses to avoid stenosis. The general principles are that we prefer a patch if it involves 50% or less of the caval wall. We'll resect and not replace the infrarenal caval segment, provided the collateral veins are not disrupted as part of the operation. But we routinely replace the suprarenal segment and we routinely reimplant remnant renal veins. When we're dealing with patients that have large tumors and they need concomitant major liver resection, thus far we've preferred in situ techniques because we believe they have broader applicability than ex situ ones. Graft configurations vary. They're generally straight, though sometimes in the perirenal segment, as shown here in the middle image, we have to become a little creative, and in this patient, both renal veins were reimplanted. As with anything in open surgery, exposure is everything, and this is based on the size and the location of the tumor, the veins that need to be isolated, and the body habitus of the patient, especially the width of the costal flare. If we begin at the bottom, we'll work toward the diaphragm for the exposure of the lower IVC and iliac veins. The lower aorta and common arteries need to be mobilized. When you're dealing with the caval confluence, there can be between 1 and 3 small, thin-walled or broad-based lateral or middle sacral veins, which can cause troublesome bleeding, especially in a reoperative or in a radiated field. And this is an example of a 6-year-old man that had an invasive sarcoma in both the aorta and the vena cava that we replaced 17 years ago. Interestingly, his aortic graft went on to occlude, from which he's asymptomatic, but the caval graft remains patent. When we expose the suprarenal vena cava, it's done with the right medial visceral rotation. We'll mobilize or fully mobilize the liver to gain access to the retrohepatic cava, but we'll use an anterior approach which requires ligation and division of between 1 and 4 caudate lobe veins to expose the infrahepatic segment. And this is an example of a gentleman that had an intracaval tumor thrombus from renal cell cancer that extended into the right atrium. He was treated with cardiopulmonary bypass. He had invasion, and he was replaced with a graft with reimplantation of left renal vein as shown here. You'll note that the upper caval graft was unsupported. He later developed a stenosis, as illustrated in the middle picture, and then had to have that stented. For larger tumors that involve the liver, we use total vascular isolation. The keys are to have a secure place for the upper caval clamp, which can be in a supradiaphragmatic extrapericardial position. And we will always test clamp the suprahepatic cava before committing to resection and opening the vena cava to make sure the patient can tolerate that hemodynamically. We do ischemic preconditioning of the liver in the course of the resection, do a parachute technique to incorporate the remnant hepatic vein because these grafts are stiff. We transfer the clamp onto the graft after the acid metabolites are washed from the liver. And very importantly, you need the anesthesiologist to give a maximum inhalation and exhalation because the tendency is to always cut these grafts too long, and this helps in predicting graft length. And then we'll often reattach the liver ligaments to avoid torsion of the hepatic vein outflow. And this is just an example of a patient so treated. He had renal cell cancer, a solitary right liver metastasis, and intracaval thrombus. And this is a post-operative CT imaging showing the caval graft in place with a short interposition graft that was used to reconstruct the left renal vein. This is an example of a complex patient, congestive heart failure, intracaval mass from a smooth cell tumor related to a prior hysterectomy. It was leiomyomatosis. The question was, how can we get into this patient that had a pelvic arteriovenous malformation with high flow and deal with this segment? We elected to do it under cardiopulmonary bypass with a brief period of circulatory arrest. 2 cavotomies were made, one in the pararenal IVC and one extending to the iliac vein confluence so we could remove the tumor from the pelvic vein, and this occurred after the internal iliac artery branches had been occluded with coils. This is probably the most complex patient that I've done. We did this patient last summer, had an infiltrative leiomyosarcoma extending from the right renal vein, involving part of the right hepatic vein and extending to the cavoatrial junction. This patient also was done under cardiopulmonary bypass with a brief period of circulatory arrest with 2 5-minute reperfusion spells. We recreated the hepatic vein orifice after excising the tumor, reimplanted that onto the graft, sewed the graft distally to the left renal vein caval confluence, and then reimplanted the right renal vein. To date, our group has done 91 vena cava graft replacements for malignant disease, of which a third have been for primary venous leiomyosarcoma. The most common segment involved is a suprarenal vena cava in about 70% of patients. With those reconstructions, we've reimplanted or incorporated 37 hepatic and 28 renal veins. We've had 2 early deaths and 3 graft occlusions, and 2 of those graft occlusions were secondary to infection of the graft. If we look at overall survival for secondary malignancies, they range anywhere in single series from about 35 to 75%, depending on the location and type of tumor, as illustrated on this table. So in summary, venous bypass for benign disease is used when endovascular therapy fails. In our hands, palmovein and prosthetic ilio or femoral caval bypasses have good patency and symptom relief. Hybrid and complex open reconstruction should be used selectively because of poor patency, and primary and secondary malignancies of the inferior vena cava can be safely resected in select patients. Thank you very much.